Hello everyone. It's my pleasure to introduce you all to this another episode of 4D, which is a detailed discussion and dialogue for Indian diabetics. And today we have a very interesting topic lined up for discussion. It will be digital health. I believe the way we practice has changed over past 5 years or so, especially after COVID. And this is one silver lining that I have seen after COVID is that we all have started using digital health more as compared to previously. A number of teleconsultations have increased. Our patients are now able to consult us from distance. And not only this, even complication screening has become easier for us now. And for today's discussion, we have experts from different fields who will be discussing about digital health. We have Dr. Kumar KP, who is a cardiologist, currently working as assistant professor at Department of Cardiology at Yanpaya Medical College, Mangalore. Welcome, Dr. Kumar.
Thank you, sir.
We also have Dr. Ashwin SP, who is a nephrologist and is currently working in Department of Nephrology at Father Muller Medical College, Bangalore. Welcome, Dr. Ashwin. It's great to have you here on this
Thank
show.
you, sir. Thank you.
And,
Thank you, sir.
You're welcome, sir. And we have an eminent endocrinologist also from Mangalore. She's Dr. Saurabh Bhatt, a good friend, and I have known her for past many years, a great orator, and we'll love to listen from her. Welcome, Dr. Saurabh.
Thank you, sir.
So I believe all of us have been using digital health for past 5 years or so. So Dr. Ashwin, let's begin with you. So where do you see digital health in your practice as a functioning cardiologist? Do you find it helpful, or do you believe it is a long path to go?
So, per se, from kidney disease point of view, definitely, I think it will be the way forward, sir. Because majority of the kidney diseases are silent, and to pick the disease early, we need to have digital health interventions. And most of the times, kidney is like an innocent bystander with respect to diabetes or with respect to a cardiac failure. But the kidney damage can be, or the kidney disease can be picked up early, especially in patients who are proteinuric or in patients who have slowly progressive renal failure. In these, it can be picked early, and early interventions can be attempted.
Absolutely, sir. It is helpful, and early detection is one of the good things. And by early detection, we can prevent the later complications, I believe. Dr. Kumar, from your perspective too, have you seen an increase in your use of digital health or digital platforms over past decade or so?
Yeah, so in cardiology, I would say digital health is already incorporated in our routine practice almost. You see so many apps and smartwatches being able to detect atrial fibrillation with more than 95% sensitivity and specificity. And we also have these implantable devices which can detect minute increase in or very minimal increase in fluid status or volume overload in heart failure patients. So pretty early compared to clinical detection. So these patients, we can identify them quite before they go into decompensation, especially the heart failure patients, I would say. So if we detect fluid accumulation, we can advise them appropriate modification in their medications, modifications in their fluid intake, ultimately preventing hospitalization to the burden financially as well as physiologically, pathologically, there's a downhill course of each hospitalization. So we avoid all that. So digital health or incorporating technology into our day-to-day practice, I think is way forward and it's quite rewarding.
So I believe cardiologists are one who are using the tech the most, and probably it is the emergency of the disease that has led to more use of tech in this field, because we have seen a lot of tech devices now detecting atrial fibrillations and abnormal rhythms, and these watches are now even able to communicate to their caregivers that yes, something is going
Absolutely.
wrong, we need to contact this person. You're absolutely right in this, Dr. Kumar, and I believe cardiologists are the people where we need to follow. Probably we need to first listen to Dr. Saurabh for what it has done in field of endocrinology, and I am really excited to hear from her because we have been using quite a lot of tech in our.
Of course, you will know much more than me regarding this, but yeah, similar to what Dr. Kumar was saying, routine consultation happens regularly since COVID. That is a very important thing for us, especially when it comes to management of gestational diabetes, where patients in pregnancy they can't travel long distances, so it becomes very helpful for tight control of blood glucose to avoid complications. So that way. Then regarding gadgets, we all know that continuous glucose monitoring has really changed and it has been incorporated in the guidelines. But in the setup where I work, actually, many patients are not able to afford it long term like that because of the recurring cost. But CGM has really helped, at least in type 1 diabetics, to achieve the glycemic targets. And of course, we know that insulin like pumps are actually a revolution. So hopefully, a lot of other patients in our setups will be able to afford it. The artificial pancreas, that is the Dexcom. Are you using? In a lot of patients.
So I have a few. So again, cost is one of the challenges that we face in our OPD as well, especially in tier three city where I'm currently practicing. It is difficult, but yeah, there are patients who are using pumps and everything. So I have both types of patients in my clinic, and we have been using tech in all of these things. One another thing which has helped me over the years is now we are. You might also be using the fundus camera. Now we can just generate an image and it is related to a ophthalmologist, and we get the report right in the clinic itself. Within 15-20 minutes, we get the report, and that has really helped us to pick a lot of patients because you do advise them to get a fundus examination done, and then it is never done when they come back because they don't want to go to another doctor, and they don't feel because the visual loss occurs at a later stage of the disease, and they don't understand that if we are able to pick it early, probably we'll able to save their eyesight. That is where
Conversely, I'm interrupting. Conversely, we are able to detect diabetes with the retinal images. Actually, we just submitted a scoping review recently with an ophthalmologist from Yenapoya, actually. So it's amazing.
definitely. Yeah, so yeah, I believe we endocrinologists are not also far behind our cardiology friend in that matter. So, Dr. Ashwin, why is this digital transformation important to you as a nephrologist? Where do you want to see it in next decade or so? What are the things that you want to look at in next 10 years?
So one in the wearable field, sir, where in the wearable sensors that we have, see, most important thing for a nephrologist is glycemic control, hypertension control, electrolyte imbalance, and fluid status, sir. If you're able to get these things right, and that probably the progression of kidney disease can be halted or slowed. In terms of, we already have smartwatches measuring blood pressures and getting the what you call continuous glucose monitor, and there are other continuous glucose monitoring machines. Along with that, we would want also is to measure the fluid status in the patients, especially patients who are on either the dialysis population. It helps them in adjusting the ultrafiltration, or if they feel like they want to skip a dialysis based on the fluid status, we can customize or personalize healthcare. And in the non-dialysis population, the fluid status evaluation will help the patients consume how much to consume, how much not to consume. Overall, it'll be for the betterment of the patient holistically in terms of other organ dysfunction, in terms of cardiac dysfunction, in preventing the other organ dysfunction, predominantly cardiac dysfunctions.
Absolutely right, sir. We absolutely agree with you. that if we are able to look at this, the fluid maintenance is one of the challenges in chronic kidney disease patients, and if we are able to take care of that, probably problems will reduce, and the acute hospitalizations that occurs because of this will also be reduced.
And the other important thing is that we don't really concentrate on the physical activity or the lifestyle. We've got so many smartwatches which has the accelerometer and things like that, which captures the physical activity, but it is done only, I mean, it is not used to its full potential. And also there needs to be more digital platforms which has got emphasis on physical activity and also on the mental aspects of it. Improvement in physical activity will improve the mental aspects and subsequently the nutritional intake. All these three things, if we incorporate in an app or through a mobile system, I think it can do wonders. It's all small steps. I think it can do major changes, especially from a multidisciplinary point of view.
Dr. Kumar, as a cardiologist, what do you feel? How tech is going to help you in next decade or so? What changes are you seeing? Is the stethoscope going to go out of picture?
I think stethoscope has significantly gone out of the picture already. But I think as a digital aspect or technology wise, I think artificial intelligence is growing in a very big way. I think it is improving its accuracy in. See, we had artificial intelligence without knowing in ECG machines since quite some time. They used to read the machines, although it was a very basic interpretation. Now we have much better models which can interpret ECGs in a much accurate way. So I think going forward, artificial intelligence can detect or pinpoint every single abnormality which is there on the ECG, even in remote rural locations. You cannot have a cardiologist or an endocrinologist or even a nephrologist in every single town, but you have patients everywhere. So I think artificial intelligence and technology will play a significant role for the next decade. I think we'll have better tools to diagnose patients who are unable to reach tertiary centers pretty early. I think we'll have better monitoring. I think patients will be more educated to use these apps, which Dr. Ashwin has already mentioned, to take care of themselves. I think going forward, digital or technology will play a significant role in our routine day-to-day practice.
So definitely, AI is one big thing that is going to change how we practice. Dr. Saurabh, do you feel threatened by AI or do you feel it empowering? And what do you feel about the tools? Especially, we work with a segment that we always see chronic disease patients only, whether it is diabetes, obesity, PCOS, hypothyroid, thyroid. We see a lot of patients who have chronic disease. I believe one of the branches of medicine which purely deals with chronic disease segment. How do you see role of tech in this segment, and what tools do you use for this?
Yeah, definitely. Regarding the first question, I don't feel threatened. It's definitely empowering. In fact, maybe a year ago, I saw a patient with type 1 diabetes who was abroad and who was using insulin pump. He threw away the pump. He was so frustrated because his HbA1c was 10. Without a proper guidance, without that feedback, it's very difficult. So an endocrinologist will always be required to help utilize the tool well. That is what I feel. It's not just enough to have a tool, because even with insulin pumps, the pump can get blocked. They can have diabetic ketoacidosis. They may not even realize. So a guidance and regular checking, cross-checking with the glucometer is required that way. And we have these programs like the Twin Health, and like where that is something that I feel like to improve the lifestyle changes, to modify and guide them. Such platforms, people needs more, I think, research backing to use these, where that can guide them well about the lifestyle changes that they can have. So for that, I think if the endocrinologist encourage them to use it, they may use it. Otherwise, on their own, it is very difficult to use. But definitely, it is empowering. If CGM especially becomes more widely available, we can follow the guidelines strictly and avoid the pricks, multiple pricks in a day. Like still for type 1 diabetics, 6 to 12 pricks a day. So CGM will reduce the pricks. 6 to 12 pricks for only glucometer reading, plus again the insulin pricks 4 times. So for a child, 12 to 15 pricks is not easy. So I think digital health will definitely help that way.
You're right. Definitely, it helps use text like CGM and AI. Definitely is empowering, and you are absolutely right that just having insulin pump doesn't equate to a good glycemic control. We need to and how it can be used and what decisions are to be made on the basis of the data that it provides. Uh, Again, in obesity care also, uh, we can actually look at the number of steps now. Most of patients are using the step counters and they are doing their steps, and it actually is an extra motivation for them. It actually provides. So, what I tell my patients is look at your steps at around 4 or 5 in the evening. If you are still off target, that means you need to buck up for the rest of the day and probably need to do those extra steps. And actually, they come and share with me whatever they have been doing. They make a log of their physical activity, and this is how actually tech helps in managing chronic disease. But Dr. Kumar, these diseases usually do not come as a single entity. Most of your patients have some sort of renal problems as well. How do you use tech to align these chronic kidney disease with cardiac problems? How do you look at these? How tech helps in helping these?
I think we have to prioritize patients, subcategory of patients with cardiac illness and diabetes, uncontrolled cardiac disease, and CKD, cardiac disease, and something else. So that I think rather than focusing on patients who have isolated cardiac illness, I think we have to focus on patients who have multiple comorbidities. So these patients, I think, will benefit the most because they need more frequent monitoring and wide monitoring parameters, I would say, probably. A patient with CKD and heart failure will require much more intense or strict fluid management than a heart failure patient alone or a CKD patient alone without heart failure. So I think we have to prioritize digital health, remote monitoring, teleconsultation, everything in these category of patients who have multiple issues. See, if you can achieve this subtle fluid control on a day-to-day basis in a remote area for these patients, I think we can significantly prolong their, I would say, morbidity-free period, reduce the hospitalizations, the downhill course each disease has with each hospitalization is immense. So I think we have to probably select these patients who require more intense monitoring and probably empower them and motivate them to use these techniques.
Yeah, using tech helps you in understanding the physiology of these processes. Dr. Ashwin, a similar question for you. How tech helps you? Because I believe cardiovascular mortality is the most common reason for mortality in patients with renal disease. And how do these digital ecosystems help you to manage both of the diseases together? And how tech helps you in early detection and prevention of CKD?
So one early detection, coming two questions. The second, start with the second one. It is early detection is predominantly through AI detection models, because based on because you have the patient data, the baseline urine protein creatinine ratio or albumin creatinine ratio, creatinine, urine analysis. All of these, when the data is integrated and read well, I think then it helps in early detection, whom we should detect early, what sort of cohort of patients we have to detect early, what kind of patients. I think in that AI or machine learning will help. And the second part is predominantly we will have to, people with cardiac dysfunction and renal failure, whether it's a cardiorenal type 1 or type 2 or type 5, whatever, whether it's the kidneys causing cardiac failure or the cardiac causing the kidney issues, or it's an other disease like something like a diabetes causing both of these. Still, we need to be, what we need is a good and optimum blood pressure control optimum fluid status control. All this can be daily weight monitoring. All of these can be done with something like a remote patient monitoring systems. There are plenty of them available, and this will give us the volume status of the patient. This will give us what is the lean protein content in the body, what is the extracellular fluid, what's the intercellular fluid, how what is the overall obesity or the fat percentage that is present in the body. These things will help on the long run in managing the patient. Initially, it may be cumbersome, but again, these things have to be um, incorporated on a long run, or there should be a longitudinal follow for all this, so we can see how the patient has improved. Finally, we want a good hard outcome. We want hard outcome in the sense prevention of mortality, prevention of morbidity. These are the outcomes that we look at. These are the outcomes that we generally tend to look into. So all of these will help in aligning the patient, and when we do all this, I think it affects the patient psychologically, and they also become more conscious of their weight and their the blood pressure control, and in turn they themselves get self-educated, and that will help in managing the patient. I think the patient education also helps. All of these interventions will in turn aid the patient, educate them, and then overall it will benefit the patient population as well as the medical fraternity.
Absolutely right, Dr. Ashwin. So all of us treat chronic diseases. Dr. Saurabh treats diabetes, Dr. Ashwin treats chronic kidney disease, and Dr. Kumar treats congestive heart failure. I believe one of the common problems which we all face is the medicine compliance. How tech helps you? Dr. Saurabh, we'll start from you because I believe the drugs that are left are mostly from our segment. How tech helps you to ensure compliance?
Yeah, the SGLT2 inhibitors are one drug that actually has all three benefits like glycemic control as well as cardiac benefit in heart failure patients, and also can reduce the risk of microalbuminuria. So I think the adherence tracking through digital platforms may help improve the cardio and renal protection rates actually. So I think adherence as it is a little because of the genitourinary infection. Proper counseling and education, like Dr. Ashwin was saying, education is very important to ensure compliance. So before starting, if you are able to tell them that you can look out for this, and then as much as possible give an antifungal, try to continue it, and then monitor the adherence with the tracking may help.
We get some smart
And of course,
pillboxes,
the
or
endocrine, renal, and digital.
yeah, I think we get some smart pillboxes or apps that
Yeah.
help patient remind for the medications, and I think these things tools should be made use, but finally at the end it all becomes mobile oriented, and it's the other disadvantage. We're going too much into the other spectrum.
Dr. Kumar, are you using any tech for this purpose?
To not
To
really.
ensure
I think
to ensure
I
compliance.
think oral advice and educating the patients is all that we can do. Like Saurabh said, the patients that we have in our setup are not patients who can afford, or they are not so tech friendly patients that we have. They are from a poor background, generally farmers. So most of our time in OP is spent on educating patients the importance of taking these drugs, especially our post-angioplasty patients, antiplatelets. Still, we have a number of patients coming back after non-compliance and acute MIs. So we have to find a solution. We have to find a way forward to ensure compliance. But as of now, no, I'm not using anything.
I agree with all three of you. Education is the key, I believe, for compliance, and all the pill reminders, alarms. I don't believe they actually work. At some point of time, they start irritating our patients, and they just stop it. Because if we are using, say, a tech that gives them a reminder, they'll just block it. They will make it silent because they don't want to listen to that sound. And I believe it is the severity of the problem that is important for them. Uh, if I am writing a statin, I believe 60% of the times statin is one drug that is going to be stopped. And I don't believe statin is stopped when Dr. Kumar writes. Uh, Once he writes it, they'll keep on taking it. Similarly, if I am writing a diuretic or a drug related to a renal problem, probably it is a drug that is going to be left out.
Probably what I feel is SGLT2 inhibitors written by a nephrologist is more valued than written by an endocrinologist. I don't know, I may be wrong. We have two endocrinologists here.
So yeah, I also actually believe that, because we are starting it very early in the course of the disease, where we have to tell them that this is one drug that is going to help you not only in diabetes management, but also it will help you manage your kidney problems, heart problem. It will actually prevent those diseases. So whenever the word prevention comes into your sentence, the patient sees that this is not the drug that I want. Prevention is
So
not
we
about.
try very, very hard to say we want to prevent cardiac disease and kidney disease, but it's
Yeah.
never taken seriously. Only once
Yeah.
it is serious, it's taken.
Yeah, absolutely right. So I believe this is one tech that we want, where our patients start understanding the importance of that, and probably educating them is one of the ways to go ahead about it. So we talked about artificial intelligence. Dr. Kumar, how artificial intelligence is changing cardiology practice? What are the different areas where artificial intelligence is playing its role?
I think artificial intelligence, mainly for diagnostic purposes, it can better analyze ECGs, better analyze coronary angiograms, the data that we put into it. It is able to identify subtle regional wall motion abnormalities on echocardiograms. So basically, it is still in a very early stage. It is not coming to the full-fledged practice, but it is improving. There are certain models which can accurately identify some abnormalities on the echo, which we are unable to as cardiologists ourselves. So mainly the diagnostics imaging, it is coming up in a big way.
So my question is, how far is the model with where if we are looking at an ECG, a person is sitting, say, in a village, they have an ECG machine, can be there at a PhD, and it looks at the ECG and it predicts that yes, there is a problem, you need to go to the cardiologist immediately. Are we at that stage?
Yes, definitely. ECG analysis, if you see, artificial intelligence can detect ST elevation MRIs, it can detect atrial fibrillations, it can detect most of the arrhythmias, ventricular tachycardias. So, detection of abnormalities on the ECG had begun long before artificial intelligence became a big thing. So it is just a progression of whatever had begun long ago. So ECG wise, artificial intelligence is way ahead compared to any other platforms, I would say. It can definitely tell you, yes, this is an abnormal ECG, critically abnormal ECG, and you have to visit a cardiologist at the earliest. It can definitely do it.
So I believe that is one advancement that can actually save lives, because if we find a certain abnormality and if a drug can be given right at that time, probably that can also be done now. That this is the dose, if this is the weight of your patient, give this drug in this amount, and probably that patient can have a few more hours to reach to a tertiary care center where it can be managed better. So that is where I believe artificial intelligence can be much helpful in this regard. Same question to you, Dr. Ashwin. Where do you see artificial intelligence as far as nephrology is concerned?
So it's still at nascent stages because nephrology, there are two aspects to it. So one is it needs to capture the electronic health records, and from there it comes out with what you call whom you suspect, or who are the persons who are the targeted population whom we should be more worried about. So in that sense, it's still, we are at the nascent stage. We still need to go a long way. But the other field in nephrology where it can help is in nephropathology, where in the analysis of kidney biopsy sample, I think in that AI is already started to come in, and it will definitely help in the longer run. Right? So that is, but the number of patients that we do biopsy is far lesser than what we see. So there again, it is not much of use to the public, but especially from a doctor's point of view, yeah, it's very much useful from a nephropathology point of view.
Absolutely, an exciting field, I believe. I think the problem with reading a renal biopsy is real because the whole management changes, and if we
Yes.
can have something which is credible, and if we are getting a good diagnosis out of that, probably it is going to help a lot, especially in places where we don't have a good pathology backup. So yeah,
Yes.
it is one of the areas where definitely it is going to help us to reach. Dr. Sarva, where do you see AI, especially as far as type 1 diabetes is concerned? We are using a lot of things now in type 1 diabetes. Just share a few. Type 1 diabetes is one disease where I believe it is going to be of immense help.
Definitely, because hypoglycemia risk is there. So AI models, which trained on longitudinal glucose and metabolic data sets, they can predict the glycemic instability and hypoglycemia risk. Like exactly how in these insulin pumps, like the low glucose suspend feature, which can prevent hypoglycemia, like it cuts off the insulin release when the it is at below a particular level, the glucose goes similarly. So I think in type 1 diabetics, that may help a lot. And of course, like I was saying that time about the retinopathy. So deep learning models from these images are able to detect diabetes itself. And even in pre-diabetes stages, they are saying it is excellent. So it can replace even HbA1c can be replaced. Like we are able to estimate an HbA1c based on the patterns in the retina, like the venous and the arterial diameters. And some tools may actually, like that is the review that we did actually. So many new things are coming up. And of course, in diabetic autonomic neuropathy and diabetic fatigue, they're saying that the voice and movement analytics are emerging tools to screen for these. So I think AI is coming in a big way. But I think the first was the insulin pump. That itself, sadly, is not accessible with the 5 to 6 lakhs initial cost. I don't think it's even affordable to a lot of our patients. That's the problem. Otherwise, it's come so long back. So I think every type 1 diabetic child deserves a product that doesn't happen.
Yeah,
So we are
yeah.
lagging.
You are lagging. Yeah, you are absolutely right. This is one area, and I also believe that CGM is one thing that should come at a lower price by now. It is there. We have a lot of Indian companies. Probably will have a few Indian companies with a good CGM, and probably that will also help in changing how we manage diabetes. So another area where we have started using in type 1 diabetes, there are many predictive models for predicting the bolus insulin requirement. So now what you can do is you can actually take a pic of your food, and in real time it analyzes. It gives you the number of carbohydrates in that food, and you can actually get a response from that app that this is the amount of insulin you require, and within few days the app becomes more and more smarter. What it helps is it makes your curve stable. It may make it at a higher level, or it may make it at a lower level, but the fluctuations will go away, and then that makes our lives much easier, because then we just have to increase or reduce the basal dose, and it does the trick most of the time. So there is another way, and that has helped us in managing our patients who live far away from us, and it helps tech helps us in that. So we have been talking about digital health. So, our viewers would definitely like to hear some of your success stories using tech. Dr. Kumar, we'll start from you. Any patient that you remember where you have used tech that has helped and improved the outcomes? Maybe it was AI or whatever tech you have used.
Actually, I was part of a startup, I would say, called Frontier X. they started monitoring this ECG's wearable device. It was a wearable device which athletes, they were targeting mainly the athletes. They used to wear this, it's just like a strap they used to wear across around their chest before they, or any time of the day they used to wear these devices before they exercised or during exercise. So I used to, when they started this startup, I think it was during my DM 2019, I would say. So during those days, I would read the ECGs for them. So initially, most of the ECGs were normal or very few abnormalities, I would say. But when their client base or whatever, I would say, went up, we had significant abnormalities detected. Patients were asymptomatic, I would say. One patient had actually ventricular tachycardia detected on this device. So we had to contact this person immediately. The data we read probably 24 hours later. It was a silent episode which lasted 30 seconds. So we had to contact this person immediately and to consult a cardiologist. So ultimately, he had to undergo the EP study, RF ablation. So I think this is one of the success stories, I would say, which we were able to identify only because of technology. There was no other way. If we did not have this tool, we would have probably had a significant or serious event and then landed up with some LV dysfunction, or probably he would have lost his life. So this was one of the significant achievements of technology in my practice, I would say.
Yeah, great story to hear how tech saved the person. Dr. Ashwin,
Sir, for us, the most important thing is uptitration of drugs, sir. ARBs and SGLT2 inhibitors, and addition of finerenone, and uptitration of finerenone to 20 milligram. So every 2 weeks, 4 weeks, get a creatine, potassium. It becomes cumbersome for the patient to come. They can check at the local place and teleconsultation. This we can do it on a regular basis. So, probably this has been following this. So it really helps. I mean, we can go up on maximum dose. Otherwise, what happens? They generally want to come after 2 months. It's 2 months, and then by the time we uptitrate, it takes about a year, and even to check whether there's hyperkalemia, drug-induced hyperkalemia. It is useful for both the ways, but I think this is the very commonly done thing, and it's like a day-to-day, day in, day out thing done.
Yeah, absolutely right. This is what we also face the challenge whenever we are using the finerenone. Hyperkalemia is one thing, and again, like I was saying, it is usually 2 months or 3 months when we call them back, and up titration becomes challenging if you wait for that amount of time. Absolutely right. Dr. Saurabh, I believe you must have been having many stories.
Yeah, one of the earliest was like long back, even before my DM. Actually, when I was working in St. John's, if I'm interested in endocrinology, I worked for a short while there. So that time, when I worked in endocrine department, there was a lady, early days of the pump, actually insulin pump, and very few could afford it. And she was type 1 diabetic lady, and her HbA1c was never controlled, always 10. So you know very well that it has to be below 6 or 6.5. Very difficult to achieve. But at least she, because of the pump, because of her when she was planning pregnancy, her HbA1c for the first time came down, and she had an uneventful, smooth pregnancy. No polyhydramnios, no macrosomia, no complications. So that was one success story, but that was so long ago. So the problem is, like, after so many years, now I'm in a setup where patients just become a theory. Like, I just explain they can't afford it. Like, I have a twin. So I saw recently a pair of twins, both type 1 diabetic. So they're so scared of insulin pricks. So they close their eyes, one pricks the other, and the other pricks. So they prick each other. It is such a sad state. I'm not able to do anything about it. So affordability is digital, a limitation for digital health.
Yeah. So actually, you had a double story. The mother and the baby both were healthy, so that was a double success. I think.
Yes.
So before we go, I'll just share my story. So this was my first ever teleconsultation, and it was right After 3 or 4 days, the total lockdown was announced, and the whole country was in a standstill. Everyone, we didn't know what to do. The transport was also, for the initial 4 or 5 days. The transport was also a problem. So I got a call, and this was from a worried mother that her son has been having symptoms like polyuria and for the past few days, and he has been losing weight. And they got his sugars checked. Those were around 500. Ketones were positive, and since they could not travel, uh, and he was in a village, it was difficult for me to manage. So I asked him, just I want to look at the patient. So I did a video call. That was my first ever video call. Which I looked at the patient, and he was not that thin built. He was maybe around 60 kgs. He was 22 years old, and not his appearance didn't look like a typical type 1 diabetic patient. But since he was having ketosis, we had to start him on insulin. So he had a medical practitioner working near his house. So we started him on fluid, and we gave him subcutaneous injections, insulin subcutaneous. And I got call after every hour for first 8 or 10 hours that this is the sugar now, what to do. And I was really worried about the stacking effect, but we had to do something. We were able to manage, and the next thing that my mother worried about was type 1 diabetes. So I said it is, by looking at him, I don't feel it is type 1, and fortunately it turned out to be a type 2. His C-peptide was good. When we again worked up, his GAD was negative, and he's on my follow-up now, and he's just on a gliptin and metformin, and he's doing good.
Wow.
So that was one of the success stories. That was my first experience with tech, and that was something that that really helped.
Adventures.
This is
Nice.
how I using taxes. And so after that, I started using teleconsultations quite a lot.
To manage DK as well.
Yeah, so we managed DK, but we didn't have any choice at that time. So it was something that had to be done on calls only, because there was a lot of confusion at that time. All of us were worried. We didn't know what was going on. None of the healthcare, because our staff has also left. So I was working in a private setup, and it was really difficult. I remember my wife is a gynecologist, and she had a patient who had to be delivered, and she was the only person standing in the hospital. Her staff was not there. She got her delivered. So I remember that time. That was really a difficult time to me.
Like a Three Idiots situation.
Yeah, it was exactly.
One more area actually, I wanted to mention diabetic foot also, foot ulcers through digital images, the healing. They are doing that. Dr. Sanjay Kindra, that team actually is collaborating with the Enopoya, the surgical team, and doing a lot of research in that area.
Definitely, that is one area where AI and digital technology will help a lot in coming years. So we have been talking about digital health for past, I believe, 1 hour or so, and it has been absolutely fascinating to listen to you all. So how I passed this 1 hour, I just I looked at my clock, and it shows 9 p.m. It was wonderful talking to you all. Any last messages from you all to our viewers? Dr. Kumar, you will begin. Any last?
I think tech is the way forward. We all have to adjust and get used to it rather than staying away from it. We have to use it to our advantage and patient's advantage.
Absolutely right. Dr. Ashwin?
It's a tech, research, and clinicians go hand in hand. I think we need each other's help and also the patients. Without one, we do not, without anybody's, other people's help, we do not progress forward. It has to be hand in hand.
Dr. Saurabh, any last words?
Yeah, again, in the setup, I feel tech should become more affordable. But yeah, someone should lead the way, maybe in the bigger cities, and then it will follow. becomes more affordable. But tech is definitely the way forward. It's going to help us. It's going to complement the clinician's skills, not replace it
Yeah.
entirely.
Absolutely right. So the message we get here is, don't be afraid of tech, embrace it. It will never replace you, it will help. Thank you. Our experts have been phenomenal today and it was exciting. Thank you all. I'm afraid this is it from us today. We'll be joining you in our next session. Thank you and good night.